Good morning. I'd like to welcome everyone to the COVID-19 Vaccine Facts Not Fear Vaccine Safety Webinar for Healthcare Providers for January 16th, 2021. My name is Donald Moore, and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format is 45 minutes of moderator-asked questions of the expert panelists and 15 minutes of Q&A using the chat functionality. Attendees who join by telephone who have questions should send their questions to eprtraining@vdh.virginia.gov. Your feedback is requested regarding the panel discussion webinars. Please complete the survey. The link is provided in chat. Your experts panel for the morning is as follows: Dr. Norm Oliver, Commissioner, Virginia Department of Health; Dr. Michael Stevens, Professor of Internal Medicine and Associate Chair, Division of Infectious Diseases, Associate Hospital Epidemiologist, VCU Health; Dr. Josh Crawford, Bon Secours Health System, Co-Chair, VDH Vaccine Advisory Workgroup, Safety and Efficacy Subgroup. Your moderator is Christine Payne, VDH Advisory Workgroup. I'll now turn it over to Christine.
Thank you, and good morning, everyone. It's great to be with you today as we kick off this informal panel discussion. Dr. Oliver, I think it's good to review where we stand currently. So could you please tell us a little bit about COVID-19 numbers in Virginia, and to set the stage regarding the importance of this vaccine, please discuss the allocation phases of the vaccine distribution that we've implemented to immunize Virginians.
Okay. Thank you very much. Can you hear me okay? Excellent, excellent. So the numbers are distressing, as you all are well aware. We are currently more than 422,000 total cases in the Commonwealth of Virginia, nearly 20,000 hospitalizations currently in the state. Deaths now more than 5,600. The state of the pandemic is one in which you can only characterize it as very widespread community transmission. It's everywhere in the community. We are currently seeing an incidence rate of about 58 cases per 100,000 across the whole state, and in some regions it's much higher than that. The percent test positivity is over 15%. We're seeing increases in outbreaks because of this community transmission. Whenever you have widespread community transmission, that gets into congregate settings like skilled nursing facilities, assisted living facilities, and schools. And we're seeing more outbreaks in all of those areas. More ED visits. I already mentioned hospitalization. So we are in a situation where if we were relying solely on the non-pharmaceutical interventions like mask wearing and washing our hands and watching our distance, unless we were really strict and virtually near a shutdown, I don't think we could have an impact on this community spread. The light at the end of the tunnel here is the fact that we now have safe and effective vaccines, which can prevent people from getting COVID-19. And as you all know, back on December 14th, we began our vaccination campaign across the country here in the Commonwealth of Virginia. This is being done in a phased fashion. The CDC and its Advisory Committee on Immunization Practices, ACIP, came out with a framework for doing this, in which in the first phase, we would vaccinate essential workers, people who are absolutely essential to the running of our economy. They keep us fed, they keep us housed, warm, provide transportation, and all those other essential functions. Vaccinate the essential workforce, and at the same time, vaccinate our most vulnerable populations. That phase 1 was broken up into subgroups. Phase 1A, the essential workers that we're focused on are healthcare professionals, and the vulnerable population, residents and staff of long-term care facilities, skilled nursing facilities, assisted living facilities, group homes, and so on. That phase in Virginia would cover about 500,000 people. And that's what we've been focused on over this last month. The governor announced this past Thursday that we will be moving into phase 1B. Many of our local health districts started doing that this past week. Many more will do it this coming week. In phase 1B, the essential workers who will be vaccinated will be frontline essential workers. So these are people who are in frequent contact with the public. Again, as essential workers are absolutely needed for the running of our economy. It includes law enforcement, fire, hazmat, teachers, because of the importance of really preparing for the reopening of our public schools, child care workers, and others. As you heard from the governor, we are putting into phase 1B people who are 65 years of age or older, and anyone 16 to 64 with an underlying medical condition or disability that puts them at high risk for having a serious disease from COVID-19. That's the phase that most of the state will be going into starting this coming week.
Thank you, Dr. Oliver. Dr. Crawford, people are expressing concerns that these vaccinations were authorized quickly, while other vaccines have taken years for approval. Could you talk about the EUA process and how it differs from standard approval processes? Additionally, how could we be sure that these approved vaccines are safe?
Hey, good morning, everyone. So I think a lot of people wonder where mRNA technology came from and why this has an emergency use authorization EUA instead of full FDA approval. But I think a couple things to point out are that mRNA vaccines have been in the work for about 30 years. Their first reported use of successful use in animals was published in 1990. And so this technology isn't necessarily new, it just hadn't really been deployed yet. But then on January 10th of 2020, when the SARS-CoV-2 genetic sequence was released by the Chinese CDC, that's when work really did get started. But despite that, I mean, it has been developed fairly quickly. The same regulatory processes were mostly followed. They did combine some of the phases. So you saw like phase 1/2 studies being published instead of just phase 1 and phase 2 separately, and phase 2/3. So kind of as we were figuring out that this was safe in healthy individuals, they were also figuring out what dose was best, caused the least amount of side effects, and had the most potential for immunity. And then additionally, when they did phase 2 and 3 studies combined, they kind of did the same thing. They combined the studies as opposed to making them separate. And I think that they've also really done a great job in working with regulators around the world, so that wasn't bureaucracy essentially wasn't wasn't a barrier. That was really, I think, overcome very quickly. But you still had the same groups, at least in the United States, review the data. So we had the Vaccines and a Related Biologic Products Advisory Committee, the VRBAC, still reviewed this. That meeting was public. You can still find it on YouTube if you want to watch the one for Pfizer or for Moderna. And they provide evidence or advice to the commissioner of the FDA regarding if the drug should be approved or not. And the main thing that they do look at is safety first, above all else. And then also, I think over the weekend after the FDA approved or authorized, I should say, each of these vaccines. The Advisory Committee on Immunization Practices, ACIP, they met and they provide guidance to the director of the CDC. And again, they looked at safety as well. And then throughout these trials, we also had kind of another, I think, barrier, or not a barrier, but fail safe in the fact that they have something called drug and data and safety monitoring board, sorry, DSMBs. And those are independent groups that monitor these trials, and they put a stop on anything if they see unsafe signals, or they might put a pause on some. So not the Pfizer and Moderna vaccines, but you saw that happen in the United States. I think with at least the AstraZeneca vaccine, and so there are some things that there were the same kind of fail safes in place. Now the EUA, the government set out in the beginning. They said that they defined how the studies should be set up and designed. They also said that they needed certain parameters. So, for example, they wanted a certain demographic makeup to be representative of our population, and they also said that they needed a minimum of 2 months of safety data from these vaccines from the phase 2-3 studies before they would look at authorization. And then there also are some special population, I think will be talked about in a little bit, that were excluded from the study. So I think that's why you see an authorization, because we don't necessarily have as long of safety data. And, we only have 2 months for the most part. We have a little bit longer than that, but I think we have a lot of patients, the 2 month data mark. And then we don't have some of our special populations. But that allowed this to be released quickly. And from what I listened to when I listened to the VRBPAC meeting, I believe at least for Pfizer, they plan on submitting for what's called a biologic license application, a BLA, which would be full approval in April once we have more data, longer safety data, more data on certain special subpopulations. And so really corners were not cut, as I think people like to say. They went through the same processes. They just were able to kind of group some things together as opposed to them being separate. And I think the last thing I'd like to point out is just the robustness of these trials. And this is something that you can't necessarily replicate. You almost need a pandemic to replicate this data. But another reason that these things can take so long is because you need to get a certain amount of prevalence of a disease in the population. And just in modern day, you don't really always have that. But as a comparison to some other very well-known, I think, vaccines, one called Shingrix for shingles, there were about 15,000 total patients in that trial prior to full FDA approval that received either placebo or vaccine. Fluzone High Dose, which is you see that on TV all the time, touting its benefits for influenza prevention in 65 up population. That was studied in 31,000 patients prior to full FDA approval. And then one of the pneumococcal vaccines, Prevnar 13, was studied in about 84,000 participants before full approval. And in contrast, these two mRNA vaccines combined were studied in over 70,000 participants in the trials. And so, they're at least on par, or I think better from a robustness standpoint than some of our current vaccines that are recommended by ACIP and are fully FDA approved. So it was done quickly, but I think the proper steps were followed. There was a lot of transparency, and there were a lot of patience, which I think is also really helpful when you're trying to detect key safety signals. And I think there's some other questions about that later on. So I'll stop there.
Thank you, Dr. Crawford. Dr. Stevens, help us understand the two vaccines we currently have available. Specifically, how do the mRNA vaccines work? What additives do they contain? And what are the differences between the Pfizer and the Moderna vaccines?
All right. Thank you, Christine. Yeah, so traditional viral vaccines contain either weakened whole virus or viral components. And those are used to stimulate your immune system, so you'll recognize the virus should you encounter it out in the world. And what's different with the mRNA technology is it doesn't contain any virus whatsoever. It includes code for a little tiny piece of the viral sort of one of these things that shows up on top of the virus. And so your body's own factories, the ribosomes, produce that protein once it gets that code, and then your body looks at that and learns how to respond to the virus. Importantly, there's some important things to note about that. The mRNA technology has nothing to do with DNA. It doesn't go into that area of the cell. It does nothing with DNA whatsoever. The mRNA itself actually is broken down in the body very rapidly. And so that's gone very quickly. And otherwise, they sort of work like normal vaccines. But one of the great things is you can mass produce the vaccines more quickly because you don't have to grow virus, or you don't have to break down virus into components. And so that really is a sort of a win for science. And just like Dr. Crawford said, these things have been studied for decades. And so the technology, is not truly new, but the deployment's new. You talk about the differences with the Pfizer and Moderna vaccines. There's some key differences. They're really sort of, they're minor though, and largely they can be looked at as equivalent. You can't look at them as equivalent in terms of you can switch the series. Like you start Pfizer, you end Pfizer. You start Moderna, you end Moderna, because that's how they're studied. But they both use mRNA technology. They're both wildly effective. The Pfizer at 95%, the Moderna around 94.1%. Important to note that both of them, even if they don't prevent disease, people get less sick if you get the vaccine. And that's a huge important point. They're different a little bit in terms of when you get the vaccine. Pfizer at day 0, day 21, Moderna at day 0, day 28. They're a little bit different in how you store them. And they really haven't been compared in trials or anything like that. But from a practical standpoint, you should look at them as equivalent, meaning people and your patients should go with what you have access to and look at them roughly as being equivalent. You did ask about things that they contain. There's really, beyond the mRNA platform, they contain things that look sort of like polysorbate. And so there's not a whole lot of sort of interesting additives or anything like that. Dr. Crawford could probably speak to that in more detail. I'll stop my comments there. Thanks.
So much, Dr. Stevens. I do want to remind our attendees that if you have additional questions, or if the conversation is sparking some new questions that you might have, please enter them in the chat. Dr. Crawford, we've discussed the differences between the two vaccines. Could you help us understand what we might expect after receiving these vaccines? What type of side effects are likely to occur from the vaccines? Can we manage them with over-the-counters like NSAIDs or antipyretics? And then also, could you discuss your thoughts on the severe allergic reactions that have been reported thus far?
Yes, we could probably spend an hour talking about the data, the safety data, whatnot. So I'll just try to hit a few of the high points. Overall, we haven't seen a lot of severe side effects. And again, there were 70,000 participants. Half received the active dose. And I think we've had 10 million, people, or over 10 million people now in the U.S., I believe, received this. And so far, there have been no deaths attributed to this vaccine. I think that's important to note. And from a severe side effect standpoint, we saw a few reported. There may be some association with Bell's palsy, but that was in 4 people out of 18,000. So again, and we're not sure that was something that's just an adverse effect of special interest that's kind of being followed ongoing by the FDA. And then lymphadenopathy also, but that's probably more so a sign that your immune system is having a response to the vaccine as opposed to I would say a true side effect. And so I think those are a couple key things to point out from a side effect standpoint of what to expect. So if you were telling your patients, or just from what you to expect personally, I would expect some injection site pain. I haven't spoken to someone yet who hasn't had a sore arm for a couple of days. I kind of equate it to more of like what you see with like a Tdap versus the flu vaccine. Tdap tends to have a little bit more injection site pain than others. So maybe some redness, maybe some tenderness, and that goes away after a day or two. And that's it's transient. It goes away, but it tends to happen after each vaccine. An interesting side effect we've seen with Moderna, anecdotally, and it was published in their paper that came out on December 30th, was like a delayed injection site reaction. And that was about 7 to 8 days after mostly the initial injection. The second shot, it wasn't as prevalent in the study, at least. So about 1% of patients experienced a rash at the injection site that occurred about a week after the injection itself with Moderna. and that went away after about 4 to 5 days. So I just wanted to point that out because I thought that was an interesting side effect. From a systemic side effect standpoint, that was really well studied, I think. And what we saw, I think, want to point out some data and then a few key points. One, we saw about 15-16% of patients after their second dose end up with a fever. Most of those were low grade, but technically a fever. About 60% had reported some level of fatigue, although 20 to 30% of people in the placebo group also reported that. About half of patients reported having a fever, again, mostly after the second dose, and about a third of patients had a fever in the placebo group. Chills, about a third of patients in the treatment group and after the second injection, not too many in the placebo group. About a third experienced muscle pain, about a fifth experienced joint pain, and then about half used an antipyretic to manage symptoms after that second dose. And a little under a third, actually more like a quarter of patients use an antipyretic to manage side effects after their first dose. So I think what I'm getting at is that you're going to see these systemic side effects. They're going to happen. They are mostly mild. They are transient. The onset's 1 to 2 days after injection, although I'm kind of hearing anecdotally more like 12 to 24 hours after your injection. And again, a good counseling point is that these are more severe in people after the second dose than after the first dose. And again, I'm hearing that anecdotally, and the data also says that. And the other thing, I think, key point is that when they broke out 18 to 55 and then 55 and older, the side effects are actually lower in the 55 and older population across the board. But when they looked at efficacy, and I know there's questions on efficacy, when they looked at efficacy, it was similar for 55 and up and 18 to 55. That's how they broke it out in the Pfizer vaccine. I think Moderna, they did 65 and up and 18 to 64, but same principle. So again, older patients tend to have less side effects. The side effects are mild, they're transient for the most part, and they're more prevalent after the second dose than after the first dose. There are some theories that if you've had COVID, you might have a little more of a reaction to the vaccine from side effect standpoint. That's kind of, again, anecdotal right now because those patients weren't, necessarily studied, but that was kind of the thought behind that. So yes, you can manage this with antipyretics. I wouldn't take one before you come in, but I would take one, if you had any sort of symptoms. From an actual reaction standpoint, these have been pretty rare overall. They are none have been fatal. MMWR published a nice piece on this January 6th. Median time to a reaction, this kind of anaphylactic type reaction, was 13 minutes after the injection. Interestingly enough, 90% of the patients were female in this particular report that came from VAERS. 86% reacted within 30 minutes. About 17% were hospitalized, but again, all survived. And almost everybody was treated with epinephrine. And 81% of the patients who had a reaction had an allergy to food, plants, drugs, or stings reported. And so I think overall, if people wait 30 minutes who have a history of allergies, then I think that's a fair amount of monitoring, and you'll catch most of these severe reactions. But again, 21 out of millions that we've done so far had a sort of severe reaction. So overall, pretty rare.
Much. And sorry, the sun's coming in on me now, so I'm all blurred out. Dr. Oliver, let's come back to you, discuss post-vaccine monitoring. What do we have in place for immediate and long-term monitoring for our recipients?
Thank you, Christine. Well, as Dr. Crawford just said, the number of severe allergic reactions that we've seen out of the 10 million plus administered doses that have happened so far has been a very small handful. But out of an abundance of caution, our vaccination sites are all staffed with healthcare professionals who are prepared to deal with allergic reactions should one occur. And Dr. Crawford gave you the data on frequent reactions occur and the sort of time lag that occurs 15 to 30 minutes. Someone with a history of allergic reactions, we ask them to wait for 30 minutes. so that we can observe them and make sure they don't have any allergic reaction to that vaccine. And we ask all people to wait for 15 minutes at least so that we can make sure that doesn't happen. Should there be an allergic reaction, we have epinephrine, we can intervene and ensure that that person is safe. As far as more long-term monitoring, that's even more rare. Dr. Crawford mentioned some dermatological skin rashes, that sort of thing. I would say that you really don't need to do much in the way of long-term monitoring.
Thanks so much, Dr. Oliver. Let's discuss what we know about vaccinating special populations. Dr. Stevens, could you talk about the recommendations for vaccinating pregnant and lactating women, children, and immunocompromised patients, please?
Yes. So thank you for the question. So the pregnant and breastfeeding women were not included in the trials for the mRNA platform vaccines that are available. However, there's no reason to believe that the vaccines would be any less safe for pregnant women, breastfeeding women, or the fetuses. And the CDC, the American College of Gynecologists or Obstetricians and Gynecologists, and the Society for Maternal Fetal Medicine have all come out and said, offer the vaccine to these patients. You have to acknowledge that there's limited safety and effectiveness data, but offer the vaccine to these patients. And again, the science doesn't suggest that they would be any less safe. It's also important to note that pregnancy itself is a somewhat immunocompromising condition, and this may be a population that has more issues with COVID-19 should they get it, and also may have comorbidities that put them at risk. And so when you look at the risk-benefit analysis, it's really on the benefit side. So that's what we know so far. Now, when we talk about children, unfortunately, those questions won't be answered for a while, at least in children less than 12 years of age. Currently, studies are enrolling for the mRNA vaccines in this population, but enrollment is slow, and we don't really expect to get any kind of formal EUA or approval probably before 2022. And so that has to do with the fact that the studies are enrolling so slowly. In terms of immunocompromised population, so across all comers, this is a population that does worse with COVID-19. And so really at high risk for morbidity and mortality. We don't have great safety and effectiveness data for these mRNA vaccines in this population. We have some limited data from patients living with HIV from the Pfizer vaccine studies, but there's no reason to believe it wouldn't be safe. Just like other vaccines, when you're immunocompromised, you have some immune dysregulation, whether it's from the underlying disease process or from the medications being used to suppress the immune system. You may not respond to vaccines as robustly as if you didn't have an immunocompromising condition. This is true for all vaccines, and it's the same scenario. And we give the vaccines, and I would suggest that people give these vaccines as well, because it may help, and they're at very high risk should they not get the vaccine. And so that's sort of the state of the state with our understanding of these special populations.
Thank you. Also, what about patients or folks who have already gotten the infection? They've already been infected with COVID-19. Should they still get the vaccine? And if so, how long do they need to wait before getting vaccinated?
Christine, to clarify, that's a question for me?
Oh, yes. Sorry. Yes, Dr. Stevens.
Oh, no. Just making sure. I don't want to take away anyone else's thunder here. All right. So what do we know about this? So the bottom line, from a practical standpoint, in terms of our understanding of immunology, as soon as they're out of quarantine and they've recovered, they could get the vaccine. And there may be some benefit to getting the vaccine. We don't really have a firm answer to this, but they could get it and it may help, and people should do it. Now, the current recommendation is to wait 3 months. And this is more of a population sort of practical recommendation, because it's very unlikely someone's going to get reinfected within 90 days. And so we have a limited vaccine supply, and this opens up that vaccine to somebody who hasn't been infected yet and probably doesn't have any immunity. And so the recommendation is to wait, 3 months and then get the vaccine. So that's important. The other thing I'll throw out there, because it's something other people may be, it's related, is people who get the monoclonal antibodies. They definitely have to wait. So if somebody gets infected, gets a monoclonal antibody, they should wait 3 months because they may not respond to the vaccine. And that would almost be a sort of a waste of that vaccine dose. And so I'll stop there.
Thanks so much, Dr. Stevens. Dr. Oliver, we know that both the Moderna and Pfizer vaccines require 2 doses. What are the mechanisms in place for documenting vaccine administration and for second dose reminders?
Thank you, Christine. The Virginia Department of Health maintains immunization registry called the Virginia Immunization Information System, or VIS. And those of you who administer vaccines are familiar with this registry. For end-to-end management of the vaccinations, we are using a system established by the CDC, the VAMS, it's a Vaccine Ambulatory Management System. And we can track through that means when people receive their first dose and when they will be needing their second dose. When you get your first dose, there's also redundant systems. We give people a card, tell them on that card when they should return for their second dose. If they have cell phones, we can contact them that way, both through pushing text messages and obviously through calling them and tracking that way to get them back for their second dose. Providers must be registered with our registry, the VIS, and through looking into the VIS, they will be able to identify when their patients need to have their second dose administered. I should also mention that VDH is in the process of standing up another system called PrepMod, which will be another end-to-end management system. This is something we've already partnered with health systems around the Commonwealth to provide them with this technology, and we'll be using it as well. So there's a lot of ways in which we'll be tracking this. People will definitely know how and when to get their second dose.
That's great. Dr. Oliver, could you also tell us how healthcare professionals might find out if they're vaccine eligible, where to go, and when they can get their vaccines?
Certainly. If you go to our website, vdh.virginia.gov, there's a button there for COVID-19 vaccine. It'll take you to our vaccination response page, which lists the 3 phases that are currently, or the 2 phases that we're currently in, and the one that we'll be going into, phases 1A, 1B, and 1C. Beneath those boxes is a button that says find out which phase you're eligible for, and you can click on that and it will take you to a tool that will, when you walk through it, will tell you exactly what phase, what category you fall into, and that's true for health professionals as well. And from there, you can, through your, if you're affiliated with a healthcare system or large group practice, or even if you're a community-based physician or a healthcare professional, you can contact the local health department and then find out when you'll be able to get a vaccine.
Thank you. What about the general public, Dr. Oliver? What's planned for people who don't have perhaps access to an online sign-up system, and how do they learn when their turn comes up?
People who don't have access to anything online, I would suggest that the best thing to do would be to call our call center. That's 1-877, what is it? Ask VDH3. So we can drop that in the chat. People can get that telephone number, and the call center will give you the information that you need to find out, one, about eligibility, and two, where you can go to get a vaccine if you're eligible to do that now.
Thank you, Dr. Oliver. Dr. Crawford, I'd like to ask you to talk about our pharmaceutical partners. Is there a cost or a copay associated with the vaccine? And are there residency requirements? Dr. Crawford?
I'm still muted. Sorry. There shouldn't be there should not be a copay. The federal government has provided this free of charge to us. Now we can bill, your pharmacy, physician office, whatever, can bill your insurance for the administration of the vaccine itself. But I believe under the Affordable Care Act, I think one of the laws that preventative medicine, in which vaccines fall into, are covered 100%, should not have a copay. And I think that has to be enacted by your insurance company within 15 days of an ACIP recommendation, I believe. So that means we're post 15 days at this point, so that they should all be covered. But hopefully, but you may be asked to provide your insurance information when you're receiving this particular vaccine. From a residency requirement standpoint, honestly, I'm not really sure. We were on a call yesterday with Dr. Avula, who's kind of the field general, I think, as I've heard, for the COVID vaccine in the Commonwealth of Virginia. And he kind of did allude to the fact that there might be some people crossing state lines who live in some of the borders. And I don't want to speak for him, but from what I kind of heard was, we could give them the vaccine. A lot of them may also work in Virginia. I think Virginia, and Stephanie from VDH could probably correct me if I'm wrong here, but I think in Virginia we did send some vaccine to DC because we have a lot of people that work there in the District of Columbia that live in Virginia, and they did not get a lot of vaccine in DC to their health systems initially. So I don't have a great answer to that, but it sounded like, as long as it was reasonable, they live kind of across the border. And had a reason to be in Virginia. They didn't come from, Tennessee and drive in from, Nashville to get a vaccine because we had a clinic or something. I think that's the reason. And then from a partnership standpoint, from what I understand, Walgreens and CVS have been taking on vaccinating our long-term care facility residents. I've kind of heard a little bit about how that works. They come in, they set up a date, they try to get the waivers signed ahead of time, and then they come in one day, and if you want the vaccine, you basically get it as a resident. They come back 21 or 28 days later, and they give them their second vaccine. So they are taking that. I don't know the exact role right now of our of the other, Kroger's and Walgreens, CVS's for the community. I do believe the plan is to get them involved. I don't see how we can't, if we're gonna get to, our goal of I think 50,000 immunizations a day. But I don't have those plans that I can speak to right now. But I imagine that they'll be involved sooner than later.
Thanks very
Christine,
much.
if I could say just a word on that. VDH currently has a memorandum of understandings with close to 200 pharmacies across the Commonwealth. We most definitely, Dr. Crawford, will need the pharmacies across the entire state very much involved in our vaccination campaign. Phase 1B, with all of the folks who are currently eligible in that phase, is about 5 million people. We're not going to vaccinate them unless we have health departments, healthcare systems, pharmacies, community health centers, free clinics, community clinicians all involved in this effort to vaccinate this population. We're at the very beginning of that process. We haven't got to the point where we've been able to get vaccine into the hands of all of those providers, but that is the plan. And we'll be rolling that plan out over the weeks and to come. So, just to address that a little bit.
Thanks, Dr. Oliver. It sounds like we need all shoulders to the wheel.
Exactly.
Yeah. Reports recently have indicated that the U.S. is faced with a new and more transmissible strain of the virus. Dr. Stevens, what do we know about whether the available vaccines will work against these new variants? And more broadly, how will being vaccinated affect COVID testing results?
Thanks, Christine. I think from the 20,000 foot view is we need to all watch how the science evolves on this. We don't fully understand this. There's some limited data for the Pfizer vaccine where they looked at sera from 20 people, and the vaccine for folks that had been vaccinated fully still was effective against the major mutation that's present in the variant from the UK and South Africa. So that's comforting. And Moderna has come out similarly, although hasn't provided data yet, and said we think it will still work. That's great, but I think we need more information for sure. And so we all need to sort of watch that space. In terms of the second question, the vaccines will not affect the tests that are used to diagnose acute infection. So if you're vaccinated and you get COVID-19 because you hadn't built immunity yet, someone's going to they should use a PCR-based test on your nares or nasopharynx, and that test is not going to have a false positive because you were vaccinated. It could have a positive for the antibody test in the blood that shows you had been exposed to the virus at some point, but that's not a test used for diagnosing acute infection.
Thanks so much. I appreciate that, Dr. Stevens. Dr. Oliver, let's talk about how to make vaccines available to our vulnerable populations and the underserved communities in the Commonwealth. Could you share with us plans VDH has for equitable distribution of these vaccines?
Thank you, Christine. As I mentioned a moment ago, we're going to be partnering with lots of those to get the vaccine out as widely as possible. That will include doing some mass vaccination sites in very populated areas of the Commonwealth. We're in the process of looking at setting up 10 to 12 of these sites right now. As community-based providers, these mass vaccination sites and pharmacies are providing vaccine to the largest proportion of the population. The health departments in parallel will be partnering with our friends with community health centers and free clinics to really target and get the vulnerable populations and communities in the Commonwealth vaccinated, making sure we get into the housing projects, getting mobile units out into rural areas where people aren't going to be able to necessarily come in to a mass vaccination site, and those sorts of things. We are doing some of that now, and we will step that as vaccine becomes more and more available. The other thing that I think is important to note here is when you essential workers are among this essential workers, Black and brown communities are disproportionately represented. So the people who are the grocery store workers, the construction workers, the nursing home workers, the transportation. By doing essential workers, we will be hitting a good segment of these vulnerable communities. When you look at the vulnerable populations that are identified in ACIP recommendations, that also means we're getting a large number of Black and brown people, I believe. Because of systemic racism, I would say that chronic illnesses are more prevalent in these communities. And so when we're going for adults with underlying medical conditions that put them at high risk for serious COVID-19 disease, diabetes, stroke, hypertension. You start naming these things off. Black and brown people are disproportionately represented in those populations. So in doing these things, we will also be reaching a lot of them in that way. I'm very confident that in this vaccination campaign, we will be able to distribute and administer this vaccine in an equitable fashion.
That's great. It sounds like we have some overlap in our priority grouping. So I'm glad to hear we'll be addressing all the disparities that could potentially arise. Dr. Stevens, some individuals have expressed reservations about taking the vaccine. How can healthcare providers best address vaccine hesitancy?
Well, Christine, that's a very important question for sure. When we're dealing with vaccine hesitancy, oftentimes the core of the issue is mistrust. And so it's critical that we are very transparent about what we don't know and what we do know about the vaccines. And oftentimes it's really very helpful if the healthcare provider, the healthcare professional, talks to the person who has the vaccine hesitancy. We'll have that open conversation, but leads with what we don't know. And people oftentimes will respond to that because there's an implicit understanding that that person is willing to listen to my concerns about this and have a dialogue. And then that opens up the opportunity for you to discuss what you do know. But the important thing is that healthcare professional has that direct dialogue with the hesitant person, is willing to listen to them and have a dialogue about what's known and what's not known. It's difficult work when you're trying to vaccinate, millions of people, but that's probably the recipe for success.
Dr. Stevens. Dr. Crawford, I'd like to come back to you to discuss other vaccines on the horizon. Tell us what vaccines are in the pipeline for approval now, please.
Yeah, so the main ones, I think the next one that we'll probably see authorized by the FDA would probably be from Johnson & Johnson. That is an adenovirus vector vaccine. They just published their full phase 1/2 study, I think this week in New England Journal of Medicine, in case anyone's interested. Their phase 3 trial, I believe, is enrolling 60,000 plus patients. So really robust. And the exciting thing about that is that it only requires refrigeration. It doesn't require any freezing from a storage standpoint. And it's a 1-dose vaccine instead of a 2-dose series. And so that one, I think, is very exciting. We hope to see their preliminary results of the phase 3 trial later this month and potentially FDA authorization in February. Obviously, I don't control that. This is just what I'm reading. And then we have some other ones from AstraZeneca, Novavax, Merck, and Sanofi Pasteur in association with GSK. So a lot of the large big pharma is out there developing vaccines, and they all have their different characteristics. We really just don't have a lot of information on those. But the next one that I think is promising is this one from Johnson & Johnson, and the logistics would be so much easier if we can get a 1-dose vaccine out. So look for that sometime in February for potential release, from what I'm reading, in sometime in March.
That's great. Thanks. It does sound promising. I'd like to take the opportunity now to thank our panel, Dr. Oliver, Dr. Stevens, and Dr. Crawford, for taking the time to inform us. Knowledge is power, and we have the power to combat this virus. Now, let's turn the conversation to my colleague, Dr. Wendy Klein, to address questions submitted in the chat box. Dr. Klein?
Thank you so much, and I would like to take a moment to thank you for your for stepping up as moderator. I'm going to do the vaccine safety panel version of speed dating here because we had some excellent questions. So this is speed Q&A. They fall into a few categories. Pre-treatment again came up, dealing with reaction to the vaccine. I think it's been made clear about how to deal with side effects, but what do we know about the use of NSAIDs or anything else to pre-treat? Dr. Stevens, can you take that?
Thank you, Wendy. Yeah, so you could potentially, at least theoretically, blunt the immune response by giving NSAIDs or Tylenol before therapy. It's okay to do it afterwards. Once you start having side effects, you got the vaccine, you can do it. Don't do it beforehand.
Excellent. Excellent. Dr. Oliver, there have been, again, some questions about eligibility. Some of these were answered by our VDH staff and others, but again, eligibility requirements. There is a question that I thought was,
Well, the
about documentation, things like that.
right. So the eligibility requirements are fairly broad. If you go to that website, vdh.virginia.gov, COVID-19 vaccine, you can see the categories for essential workers and for the respective vulnerable populations. We are not requiring people to show up with documentation or medical record, things like that. People who feel they're in these categories can talk to their caregivers, their primary clinician providers, and find out whether or not they should be receiving the vaccine, and then go to our site to find out where they can sign up. So at the local health district level, we have registration available through the local health district. Later on this month, we'll be standing up that end-to-end management system I mentioned called PrepMod, which has a pre-registration module in it so that you can both find out eligibility and register to receive vaccines. So there'll be a number of ways in which you can do it, and we're not going to be targeting people, so to speak, in order to get their vaccine.
Thank you for that. So we should be encouraging everyone to get the vaccines. It is free and available, and there are no requirements for eligibility, essentially.
If you're in those categories, that's all you need to say.
Right. If you're in the correct phase.
Yes.
Yes. All right. Quick timing of doses, Dr. Crawford. The window of opportunity if you miss day 28. If you're a week late, you have to start all over. And what do people do about the timing of doses?
Yeah, so I think logistically, we're often telling people a specific day to come back. And sometimes that's, a little bit before or after. It's just when the next clinic is. So ACIP says that, I think for Pfizer, you have a 17 to 21 days afterwards is ideal to receive your second dose. 24 to 28 days after your first dose of Moderna is ideal. However, if for whatever reason you cannot get the second dose, maybe you're in the hospital, out of town, whatever, you should just get the second dose as soon as you're able to, following the first dose. You do not need to repeat the series. You don't need to restart it. Just get the second dose when you can. And as I think was mentioned by Dr. Stevens earlier, get the same vaccine that you got the first time.
Thank you for that. There is an interesting question about transmissibility post-vaccine. Have there been or are there currently studies in immunized patients with the vaccine regarding transmissibility rates and viral carriage? Dr. Stevens, can you take that?
Thank you, Dr. Klein. I'll keep my comments brief. Essentially, we don't really understand that point yet. I mean, those weren't the endpoints of the trials. There should be less virus to spread if everyone gets vaccinated, but everyone should assume they still could get infected and could asymptomatically transmit it. Remember, if it's 95% effective, 5% of people still got infected, and if they're infected, they could still transmit. So everybody has to keep doing everything we know works, which is wear masks, watch your distance, wash your hands, you stay home as much as possible.
Thank you for that. Another question that has been discussed but comes up over and over again, as we all know, if a patient presents who has had a history of allergic reactions to antibiotics or other medications, what do we do? Anybody want, Dr. Stevens, Dr. Crawford, should we be vaccinating people who come in worried about their risk for allergic reaction?
I could take that. So I think the answer is yes. Monitor those patients for a little bit longer. 30 minutes is what we were doing at our clinics. But I think one thing to also mention that wasn't necessarily part of the question is that if you had a severe reaction to the first dose, you would not want to get the second dose. But again, they are happening. Be transparent, but don't be transparent to the point that you scare people away from getting this vaccine, even if they have a history of allergies. A lot of people have history of lots of allergies that did not have reactions.
Thank you for that. I would like to point out to people that there are some excellent websites that have been posted in the chat. The VDH vaccine website is extremely useful, and the New England Journal has an FAQ section that's great. That's up there. Quickly, I just lost my train of thought. Back to the issue of hesitancy. We are seeing hesitancy among healthcare providers. There's been hesitancy reported among EMS workers and among workers at long-term care facilities. Dr. Oliver and the whole panel, can you talk about what we need to do to reach out to the folks who are hesitant in the medical community?
This is Dr. Oliver. I think Dr. Stevens made an excellent point in knowing that it's about trust. And I think an important way of dealing with the hesitancy is to have trusted leaders in those communities speak out as people who are in favor of getting the vaccine. And we've been working on it. We've had meetings of literally thousands of faith leaders around the Commonwealth and other respected community leaders. And we have to keep doing that. This is something we need to do every single day. The other thing I would say is just anecdotally what we've been seeing is while it's true that on the first pass, there was some significant hesitancy in the medical community. Now that people have seen everybody get those first doses, that's breaking down. And people are realizing, well, you know, Mike didn't have a bad reaction. I guess maybe I should go ahead and do it too. And we're seeing uptake in that as well. Now, I was saying earlier about how we're going to roll out the mass vaccination campaign. I do have to give a caveat here. We're only getting 110,000 doses of this vaccine every week. We have hundreds of thousands of doses available right now. We will ramp up and use those doses, and we will ramp up and use the doses that we get every week. But vaccine right now is still scarce, given what we're trying to do. So one of the other messages that we have to do in being transparent is that we're not going to vaccinate 5 million people in the next weeks. This is a months-long campaign.
Thank you, Dr. Oliver. Interesting. I mean, this last question posted again comes back to resistance and hesitancy among employees at nursing homes and among healthcare professionals and workers. And so hopefully VDH will take that into consideration to develop outreach efforts, since it is clearly a problem. I would like to remind everybody, Donald Moore is about to post a link in the chat that takes you to our survey. We would like your feedback about these vaccine panels and when and whether you think there should be more of them. Obviously, there is a need to reach out deep into the community of healthcare providers at all levels and all types and across disciplines and professions. So I want to thank everybody who's on this panel: Christine Payne, Dr. Norm Oliver, Dr. Josh Crawford, Dr. Mike Stevens, and Donald Moore for all of his help. With that, I think we are about out of time. So there is the link for the survey. And again, I thank you all. I thank everybody who took the time to attend this session. Thank you so much.